Hello everyone, welcome to this video on ischemic heart diseases. So, in this, after watching this video and series of video, you'll be able to understand what are the types of ischemic heart diseases, how to treat them, what is the pathophysiology, and what is the logic behind using each of the drugs that are used to treat ischemic heart diseases. So, let's get started. Now, when you see ischemic heart disease, you can actually divide it into types. So, first is the chronic stable angina. Okay, then you have non-ST elevation acute coronary syndrome. Then you have ST elevation myocardial infarction. So, there is chronic stable angina, non-ST elevation acute coronary syndromes, and ST elevation myocardial infarction. When I was in final year, I thought everything was same. Like, in fact, I actually thought angina, chronic stable angina, is not a disease but a symptom. Okay, but everything like chronic stable angina is different, NST is different. They differ in terms of pathophysiology, they differ in terms of treatment, and they also differ in terms of the emergencies. Okay, so let's get started in understanding each of these. Now, what happens in chronic stable angina? There is a stable plaque. In the sense, there is blockade. So, if this is the blood vessel and this is lumen, there is a plaque. Let me show you in different color. So, there is a stable plaque, means the size of the plaque remains same. What happens that during rest there is no any compromise in blood supply, but when the patient is exercising there is mismatch between the oxygen requirement and blood supply. So here the patient will have exertional chest pain, and this chest pain lasts for 2 to 3 minutes. Okay, now if you come to NST, non-ST elevation acute coronary syndromes, there are mainly two types. One is NSTEMI and another is unstable angina. So unstable angina is a completely different concept, so I won't be discussing this here. Let's go to NSTEMI. Okay, I told that in chronic stable angina the plaque is stable, means it is not changing its size. However, what happens in NSTEMI is the plaque which is there, it gets eroded or ruptured. So because of this there is activation of platelet aggregation and coagulation. So now because of the plaque erosion and rupture, there is activation of platelet aggregation and coagulation cascade. So this leads to non-occlusive thrombi. Okay, same thing happens in STEMI. So there is plaque erosion or there is plaque rupture, and there is activation of platelet aggregation and coagulation cascade. However, here the thrombi is occlusive. So it is completely occluding the blood vessel, whereas in NSTEM it is not completely occluding blood vessel. So here it is occlusive thrombi. Therefore, now coming to symptoms, because the size of plaque in chronic stable angina is stable, the patient will have exertional pain lasting for 2 to means only when he exercises the patient experiences pain. During rest there is no pain. What happens in NSTEMI? There is, because there is occlusion, like not complete though, there is partial occlusion of blood vessel. The patient has resting pain lasting for more than 10 minutes. Is this clear? Now if you come to STEMI, STEMI is even more severe. Why? Because there is occlusive thrombi. So here the patient complains of what? There is resting chest pain lasting for more than 30 minutes. Is this clear? Now the second next difference is, I told you here in stable angina the patient is having ischemia only during exercise, so you won't be able to detect Ischemia, when if you take resting ECG, you will always need stress echocardiogram or any stress scans, stress perfusion scans. Stress echocardiogram. Here in NSTEMI, what will you see? In 1/3 of the patients, you will see ST segment depression. It might be normal or there might be ST segment depression. In STEMI, what will you see? ST segment elevation. In chronic stable angina, troponin levels might be raised or not raised. It depends on the duration of ischemia. If the duration is more than 30 minutes, there might be infarction or I would say irreversible injury. If it is for less than 30 minutes, then there might be irreversible injury. Here in NSTEMI, troponins are elevated. Here in STEMI also, troponins are elevated. Then chronic stable angina, because it's stable, as the name says it's stable, here you can give medical treatment. NSTEMI also you can give depending on emergency. Okay, if the vital of the patient is stable, if the patient is elderly, cannot tolerate percutaneous coronary interventions, then you can give medical. Here it depends, it can be the treatment is medical or percutaneous coronary intervention. In STEMI is urgent. So here you should always, in NSTEMI and STEMI, you should always activate emergency response systems, and then the treatment is always percutaneous coronary intervention here, or like I would say revascularization. Okay, so this is the difference. You can broadly you can classify it as chronic stable angina, NSTEM, NST, ACS, NSTEMI and unstable angina. Unstable angina we will be discussing in separate video, and STEMI. So chronic stable angina, it's stable. The patient has chest pain only during exercise. Therefore, you can use only stress echocardiogram or stress electrocardiogram to detect this. The troponin levels might or might not be elevated. The treatment is medical. For NSTEMI and STEMI, in STEMI there is non-occlusive thrombi, there is ST depression. So depending on condition of the patient, you will either give medical treatment or you will shift the patient for percutaneous coronary intervention. STEMI is an emergency. You will always treat the patient with percutaneous coronary intervention. Okay, so this is about it. Now let's start understanding chronic stable angina in detail. Like what is the pathophysiology, how do you investigate, and how do you treat chronic stable angina. First is the pathophysiology. So the first image shows you the cross section of healthy artery. Let me use different color here. Okay, now what happens due to some injury? The injury can be due to LDL. Okay, the injury can be due to smoking. The injury can be due to diabetes mellitus. The injury can be due to stress. Okay, or the injury can be due to hypertension. So any of these factors can injure the artery wall. Can you see this, the yellow color? So now when there is injury to artery wall, what happens? There are multiple cells which get accumulated under the intima. So because there is tear or injury in the vessel wall, what is happening? There are multiple cells that is coming and getting accumulated in the subintimal layer. So this is smooth muscle, fat cells, fibroblasts. They get accumulated beneath the layer, intimal layer of the blood vessel, and what they form? They form a They form an atheromatous plaque. Now, as I told, this atheromatous plaque is stable, meaning it doesn't change in size. Now, there is compromise in the, or I would say mismatch between the blood supply and oxygen demand only when the patient is exercising or the patient is in the stress. Only that time there is mismatch. Otherwise, the patient is absolutely normal. So, because of this, the patient is having chest pain. The chest pain lasts for 2 to 5 minutes. So this is very very important. In chronic stable angina, the chest pain is during exertion, and once the patient rests, the pain subsides. So the pain aggravated on exercise and relieved on rest. The pain lasts for 2 to 5 minutes. If you see NSTEMI and STEMI, it is resting pain. Even during rest, the patient has pain. Now, if you ask whenever the patient comes with chest pain, you should always ask the patient what is the type of chest pain. Now, if you ask them, they'll say either it's like heaviness, or they'll say I'm unable to breathe, or they'll say there is something very heavy kept on my chest, or squeezing or smothering type. They'll typically describe the pain like this. And if you ask them, some patients might also, they might place their fist over the chest and say, no, it's paining here. So this is the typical Levine sign. Okay, now what would be? Patient is coming with chest pain lasting for 2 to 5 minutes. Okay, they will say the pain is like heaviness type, or the pressure type, or smothering, or choking type. Another thing is this chest pain. I'll use yellow color. Now, this chest pain can radiate to left or right arm, right shoulder. It can radiate to arm. It can radiate to neck, and it can radiate to jaw. It can also radiate to epigastrium. If you see behind, it can also radiate to interscapular area. Okay, there is a chest pain, exertional chest pain, which is radiating to shoulder or arms or neck or epigastrium or interscapular area. They might also have Levine sign. Now, once you're suspecting chronic stable angina, what are the blood investigations you ask for in the patient? What are the risk factors I told you? Like, what are the damaging factors I told? So, one is you will ask for hematocrit. Okay, then HbA1c, glycated hemoglobin. You will check patient's blood pressure, check for lipid profile, serum creatinine, and highly sensitive C-reactive protein. These are the investigations that you will get it done in a patient in whom you are suspecting chronic stable angina. Okay, HSCRP, anything above 3 nanogram. 3 nanogram per liter is considered as high risk for coronary artery disease. Next, you will get ECG done. ECG, this is very important to know that resting ECG might be normal in patients with chronic stable angina. So you should always ask the patient to exercise and then get ECG done, or stress perfusion scans done. Only then you will be able to diagnose chronic stable angina. It will be normal, it might be normal, or there might be changes of STT wave changes. The patient might have features of left ventricular hypertrophy or some arrhythmias. This is about today's video. I'll quickly recap. Okay, ischemic heart disease, there are mainly 3 types: chronic stable angina, non-ST elevation acute coronary syndrome, which can be further divided into NSTEMI and unstable angina. Then you have STEMI. So chronic stable angina has a stable plaque. The patient will have pain only during exertion, and the pain is relieved by rest. NSTEMI, they will have plaque, but plaque is not stable. There is fissuring or erosion of plaque leading to activation of platelet aggregation and coagulation cascade. So if there is non-occlusive thrombi, there is NSTEMI. If there is completely occlusive thrombi, there is STEMI. STEMI is very, very emergency. You should always treat the patient with percutaneous coronary intervention, whereas chronic stable angina and NSTEMI, you can decide depending on the condition of the patient. Biotroponin is elevated in NSTEMI and STEMI. Okay, is this clear? Now coming to pathophysiology, there is a healthy artery, but due to some stressors like lipid, like hypertension or smoking or diabetes, there is damage to the vessel wall. Now once there is a damage, what is happening? The fat, the fibroblast, the smooth cells, they are all getting accumulated in the subintimal layer, leading to formation of plaque. Now once the plaque is formed, what happens? The plaque is blocking, like the plaque is narrowing the lumen of blood vessel, and it is leading to impaired blood supply. The patient will have exertional pain lasting for 2 to 5 minutes. It can be radiating. It can radiate to arms, it can radiate to shoulder, it can radiate to jaws and epigastric area. It can also radiate to interscapular region. They might also have Levine sign, where they put their fist over their chest. So once you're suspecting chronic stable angina, you will ask the patient to get hematocrit, HbA1c, blood pressure, lipid profile, serum creatinine done. You will also check highly sensitive C-reactive protein. Anything more than 3 nanogram per liter is considered as mark, like it's high risk for coronary artery disease. ECG can be normal or it can show STT wave changes. I hope this is clear. In the next video, we'll actually learn about how stress testing is done, and after that we'll learn about how do you actually treat chronic stable angina. That's it in this video.